All right, so here we are, day one, respiratory failure. The goal of this class is to fix problems using a ventilator, holding the patient over so they can recoup, heal, and get better. You'll see on here that respiratory failure, a condition which not enough oxygen passes from your lungs, and then too much CO2 is building up. You can have either one of those or both together. So don't forget, these are separate issues. And I know that we've talked about this in other classes, but oxygenation and ventilation are two separate things. You can have one problem that leads to another, or vice versa. You know, that other problem can lead to the other one. And you can have them both at the same time. Our ventilator is designed to fix that. So the two types of failure, type 1 would be hypoxemia, type 2 being hypercapnia. These are important because they do identify how we're going to treat the patient. If we have a hypoxemia patient, they need oxygen, and they need that oxygen to be able to get to the tissues. So there's a whole bunch of different ways we're going to discuss on how to fix that. And then hypercapnia, there's too much CO2 there, so we need to be able to remove that and open up those parking spaces, as Derek would say. And so let's talk about, just get a little bit further into each one of these. The primary cause of failure is inadequate oxygenation for type 1. So that means the patient is not getting enough oxygen to their tissues, and most commonly that's because of alveolar hypoventilation. The patient is not meeting their minute ventilation need to blow off enough CO2. Ooh, I said blow off enough CO2 Type 1 respiratory failure, the primary cause of failure is inadequate tissue oxygenation. So the most common reasons for that to happen would be alveolar hypoventilation. So if you think about that, your alveoli aren't doing the amount that they would need to do to meet the metabolic needs of a patient who is either the metabolic rate has gone up because they're sick, or they're just not meeting the amount of ventilation that would normally maintain the person. And then you can have a VQ mismatch, so ventilation perfusion, or a shunt. And I'm sure Derek has explained all those things to you. We'll kind of brush on them a little bit, but stuff we should probably already know by now. The less common would be a diffusion impairment or perfusion-diffusion impairment and decreased inspired oxygen. So if we're up at altitude, say we went up to Leadville and we're hiking around up there, you're just not getting as much oxygen to the tissue because your body's not able to maintain with that low of FiO2. I understand the concentration is still 20.9%. However, the molecules are further apart, so we're not able to grasp them as well. All right, we just talked about a couple of things that would cause hypoventilation, alveolar hyperventilation. So the way we're going to treat that, one, we can start off on some oxygen to make up the difference for the lack of alveolar ventilation, right? So we're going to try to increase the oxygen. But now what are we missing, though? We're also not blowing off CO2 with that. But one of the things we can try would be bronchodilators to open up the airway, so you can help to get a little bit more air going through. If you decrease the resistance, you'll increase the flow, right? Simple math, right? Or complicated math, one of the two. Respiratory stimulants, like in a neonate, we can give them some caffeine, and they can take, they'll breathe a little bit faster, a little bit more, increase their ventilation. Weight loss. So the bigger you are, the more resistance you're going to have on the outside of the lungs, and so we're going to decrease the amount of ventilation because that weight's sitting on the chest. They can't take a really big breath, so we can give them CPAP usually at night for sleep apnea. And that's going to hopefully fix our moderate to severe hypoventilation. If they get worse, we can put them on a BiPAP to give them a little bit more oomph, some increased inspiratory pressure to help blow that off. So remember, if we have hypoventilation, it's also going to lead to increase in CO2, so hypercapnia, so a larger amount of CO2 in the bloodstream. And that is also, it's going to give us another problem. It could be a problem, but we can also look at it as, hey, this is another thing that's opening up our eyes to what's wrong. We have a low PO2 and a high CO2, so we know we have some alveolar hypoventilation, or we're guessing that. This might be something that we don't absolutely recommend to do especially not while you're doing patient care, but even while you're studying. I'm not sure it's going to be helpful. So remember our equation, V equals ventilation and Q equals perfusion. So we can have a defect that occurs in the lungs that's going to cause there to be a change in the ratio, the exchange of air between the lungs and the environment, and perfusion, the amount of blood flow that's going around the body. So if there is something that is a decreasing blood flow, well, then there's going to be a VQ mismatch. If there's a problem with ventilation, we're not going to get enough oxygen into the bloodstream to be circulated around. So either one of those could cause a severe problem, making that ratio all messed up. Okay, now let's not let this get confusing to you. It's actually a fairly simple concept when we're looking at it, but it does feel intimidating. I don't know, because it's a math-looking equation or whatever. But a high VQ, if you think of a high VQ, you have a lot of ventilation. Say your upper lobes, you have a lot of air exchanging, but not a lot of blood flow. Why? Because blood is heavy and it becomes gravity dependent, so it's down low, it sinks down lower. So you have less blood flow going across the alveoli or right by the alveoli. So then the gas exchange, you have that oxygen able to be there, but there's low perfusion, so you can actually saturate the blood going by, but there's not a lot of blood going by. So it gets as it hits back into the system, it becomes dissipated and there's not as much, right? So a low VQ or a low ventilation, there's a lot of perfusion. So now think of that. Why would that kind of make the saturations go lower? Well, there's a lot of perfusion, a lot of blood going by, tons of blood going by, but the ventilation isn't a lot, right? So what happens then is you're having just a little squirts of oxygen jumping into that bloodstream, and it becomes diluted quite quickly. So one thing to pay attention to, most ventilation lifts towards the gravity independent portions of the lungs, and the normal VQ ratio is 4 to 5. One thing you should pay close attention to on an exam is if I say 8 to 10, that's the same thing. So VQ ratio is 4 to 5. Okay, let's do yourself a favor here. Page 45 in Pillbeams is going to have a big, huge list of all the respiratory hypoventilation and respiratory failure conditions. So take a look at that, and then also conditions seen with hypoxemia and hypercapnia are in table 4-1. It's weird because 4-2 is before 4-1. Doesn't make any sense to me. Anyways, high VQ disease, in the early stages, your PO2 is going to be high, and then your CO2 low. Okay, so now think of that. Why, if your PO2 is high and your CO2 is low, what's that patient doing? They're probably breathing really fast and blowing off CO2. So some of those causes would be pulmonary embolism, CHF, arteriosclerosis, pulmonary vascular destruction, and again, make sure you take a look at page 45 in the text. Okay, the low VQ diseases, early stages, you're going to have a low oxygen concentration, or PaO2, and a high CO2. And if you think of things like COPD, an obstructive disease, your CO2 is going to be high, right? And, oh, that's stupid. I'm not going to do that. So one really cool way to think about the calculation of 4/5. It just think of 4 liters of air enter your respiratory tract, while 5 liters of blood flow are going through your capillaries every minute. That ratio, the VQ ratio, is 0.8. Right, so if you divide, the 5 into 4, that's 0.8. A number that's higher or lower is called a VQ mismatch. Right, so you're getting more ventilation or less ventilation, more perfusion, less perfusion. So pay attention to that thought process. And then on this slide, your early stages of a low VQ disease would be a low PaO2 and a high PaCO2. And think of an obstruction, what an obstruction does. An obstructed airway, if that's blocked, you're not getting any ventilation through there. So your blood might be flowing, but there's no actual gas exchange. It's an extreme situation, but a good thought process, I think. Okie dokie, pulmonary shunting. So this could be one of those other subjects that people get a little confused about. But the pulmonary shunting is defined by Desjardins as having the portion of the cardiac output that moves from the right side to the left side of the heart without being exposed to alveolar oxygen. Now there's a couple different ways that can actually happen. There's an absolute shunt or a relative shunt. The absolute shunt, if you're looking at it, we normally have, it says on the slide 4%, but Desjardins says 3, and that study that's on there says 4%. But so 3 to 4% of it is actually bypassed. On the anatomic shunts, we're going to lose some of it from pulmonary vascular system by the means of the bronchial venous drainage, and then also the left atrium by the way of the Thesbian veins. And those are usually caused by a congenital heart disease or intrapulmonary fistula or vascular tumor, something like that. And then our capillary shunts are caused by alveolar collapse. So this is more of the stuff that we can fix. A surgeon can fix the other things, right? Or maybe, right? But the things that we can help to fix are the alveolar collapse. So the capillary shunts, alveolar collapse or atelectasis, alveolar fluid accumulation, or consolidation or pneumonia. So like antibiotics or something like that would help fix that. But then removal of those secretions will help us to make things better. Plus increasing our PEEP will help to shunt the alveoli open to increase or improve or decrease the shunt, I guess is probably the best way to say that. So that whole thought process leads us into the extreme shunt. Extreme VQ mismatch is going to lead to a low PaO2 and perfusion with no ventilation. So there's blood flow going by, but say you have atelectasis. So those alveoli are collapsed or they're fluid filled or whatever. They're not able to actually have gas exchange. You have blood flow going by there, however, no gas exchange occurring in there. So our pneumonia, ARDS, right to left shunt, our COVID-19 patients is very similar to that, with a really thick mucus that's blocking those alveoli from actually having any gas exchange whatsoever or minimal gas exchange. Okie dokie. Our less common causes would be diffusion impairments. So think of like chronic diseases or an increased AC membrane. So the AC membrane, alveolar capillary membrane, if there's going to be a gap, if there's a gap between there normally is a gap, but as the gap gets bigger, then you have to have a higher concentration of oxygen or higher pressure of oxygen to transfer over to the blood vessel, or in CO2 versus going the other way as well. So that increased AC membrane could cause a dramatic problem with gas exchange. All right, our chronic hypoxemic patients, they end up having a lot of issues down the road that may be masked for a little while. What can happen is in a compensated state, blood vessels supplying less ventilated areas of the lungs may selectively contract, which would lead to pulmonary hypertension. What they're trying to do is get blood flow to the alveoli that are ventilated better, right? Well, that's great and all, but it leads to pulmonary hypertension, which overloads the right ventricle, causing cor pulmonale or an enlarged heart. That muscle keeps growing and growing and growing, and as it grows, it's not only growing in width, but the thickness of the wall actually decreases the inside of the heart as well, which causes the heart to have higher pressures inside. So we're also going to have polycythemia, so we're going to increase the amount of red blood cells that are in our system. So what does that do too? It thickens up our blood. So we have a patient who's already compromised, and now we have their blood thicker, so they're more prone to clots and blockages. So then they'll also show some cyanosis, starting off on the periphery, digital clubbing, all those things that we looked at, actually page 44 in the text. You'll see those things, and they help to identify how long the patient's been in general, like they're a chronic patient. Are chronic hypoxemic patients. Those patients initially are going to be able to mask these symptoms, and we might not notice it right off the bat, but eventually what they're going to do is their blood vessels supplying less ventilated areas of the lungs may selectively contract. Their goal is to redirect the blood to areas of the lung which are better ventilated. So this sounds like a really good idea, and it works for a while, but we end up creating pulmonary hypertension. That's going to overload the right ventricle of the heart, causing cor pulmonale. So remember, when our cor pulmonale, when our heart gets larger, it's not only getting larger in size, but it's also the walls are getting thicker. So when they get thicker, they're actually narrowing the inside as well. So the chambers get smaller, needing a higher pressure. So then they end up having right heart failure. They end up generating more red blood cells, causing polycythemia. And then we notice those things like digital clubbing and peripheral cyanosis, the start of all this. So patients with BPD or bronchopulmonary dysplasia can have an 800% increase in the thickness of the membrane. That's going to dramatically cause their CO2 to rise and their PO2 to drop. And you can notice even on chest X-ray how nasty those X-rays look. All right, so our patients with bronchopulmonary dysplasia or BPD are going to have a thickening in the alveolar wall. That's typically because they had RDS or respiratory distress syndrome as a neonate, most likely because they were premature with some surfactant deficiency. Their thickening of the wall will cause them to have an increased minute ventilation to try to overcome that. And so we're going to have to, those patients, they end up getting like a lot of albuterol steroids, and then they get fed a whole lot more as well because their work of breathing is so great that they're actually chugging along and they need a lot more calories just to stay afloat. While reading through this pathogenesis, of course, there's an insult or direct or indirect, and there's going to be some activation of inflammatory cells and mediators, which are in turn going to so with the say BPD, the injury or the insult would be prematurity with RDS. There'd be inflammatory cells and mediators that are addressing that situation. There's going to be damage to the membrane and an increased permeability of alveolar capillary membrane, and an influx of protein-rich edema, fluid, and inflammatory cells into the airspace. It's causing dysfunction of surfactant. So they already had a surfactant deficiency, which caused this problem, and then now the problem is damaging their surfactant's ability to be not produced but utilized. So you'll see in week 1, I in Blackboard I had put in calculations for just about everything mechanical ventilation related. The alveolar air equation is in there. Your normal sea level barometric pressure. We're going to talk about that. There's a couple different slides down the road. So hold, please. And on any given day at sea level, there will be a variance in that 760 millimeters of mercury. I didn't actually put that on there, did I? So weather changes will cause that to change. But these are the numeric values that we're going to use as our baseline. Go ahead and calculate those two out with, and remember we're going to be practicing that on room air at sea level. Okay, and there's the two different CO2s, 40 and 60. Couple more questions for you. The ADA gradient is helpful in determining the cause of respiratory failure. So what I want you to do is practice that alveolar oxygen equation with a PaO2 of 60 torr. So your ADA gradient with a PaO2 of 60 torr. What does the ADA gradient tell us, and what does an increased gradient tell us? So if I were a student and I were wise, I would look at the instructor's notes and the questions that they're putting on the slides, and I would say, I wonder if that's a question that's going to be on the exam that's covering this lecture. I would assume so. They might even use the same numbers. So the ADA gradient, or alveolar arterial gradient, measures the difference between the oxygen concentration in the alveoli and the arterial system. The ADA gradient has important clinical evaluation utilization, as it can help narrow the differential diagnosis for hypoxemia. Well, the ADA gradient, or the alveolar arterial gradient, measures the difference between the oxygen concentration in the alveoli and the arterial system. So the ADA gradient has important clinical utility as it helps to narrow the difference between the diagnosis for hypoxemia. The ADA gradient calculation should be P big AO2 to minus P little AO2. So with the P big AO2 representing alveolar oxygen pressure and P little AO2 representing arterial oxygen pressure. The arterial oxygen pressure, PaO2, can be directly assessed with arterial blood gas. So when we draw a gas, we're going to look at that PO2 and say, okay, that's what that number is. And the alveolar oxygen pressure, or the P big AO2, is not that easily measured. We have to do a calculation, and that's estimated by the alveolar gas equation. Well, normally A gradient increases with age. So for every decade a person has lived, their A gradient is expected to increase 1 millimeter of mercury. So an abnormally increased A gradient suggests a defect in diffusion a VQ mismatch or a right to left shunt. The thing that I think is very important in this slide is the second paragraph there. In a healthy individual with a A to A gradient should be very small. In other words, the majority of available oxygen is diffusing into the blood. So the younger the patients are, the more oxygen that they're able to have diffused into the blood. The older we get, we tend to have a little bit more tissue that's interfering it, more negative things that we've done to ourselves over the years that cause us, and deterioration of the tissue that cause a defect. Again, note that each time you see a calculation that's done slightly different, it is not horrible. They are typically within means of variation, so there's a slight variation in the numerics, but the idea of this is trending and figuring out, is the patient getting better or worse, and are they close to those numeric values. When we practice for NBRC boards, we talk about guesstimating for speed and accuracy on test taking. So we have little tricks that we can do that will kind of give us a better estimate if that answer is correct or not. Let's hit you up with some gee whiz information. The PaO2 to FiO2 ratio, or the PF ratio, is a ratio of arterial oxygen partial pressure, so PaO2, to fractional inspired oxygen, so PaO2 to FiO2, right? Also known as the Horowitz index. Didn't know that, did you? And the Carrico index. And so we always look at it as the PF ratio. At sea level, the normal PF ratio is less than 500. All right, the PaO2 to FiO2 ratio, the PF ratio, is also known as the Horowitz index or the Carrico index. Didn't know that, did you? Take that. So it's FiO2 is expressed as a fraction and not a percentage, and what that is the ratio of arterial oxygen partial pressure to fractional inspired oxygen. So what this is doing is it's helping us to identify hypoxemia. And there's my furnace kicking on. Did you hear that? ARDS severity is one of the things that we will use it for. So our mild ARDS showing a 27% mortality is having it between 200 and 300. Moderate is 100 to 200, which has a 32% mortality. And severe is less than 100, equals a 45% mortality. So if your PF ratio is less than 100, you got a 50% chance of dying. That's craziness, right? Increase your PEEP. Okay, so now I'm sure you guys are all aware of these things already, but what does the hypoxic patient look like, or hypoxemic? There's a bunch of different things that we're going to see. We're going to look at our monitor, obviously, right? We're going to see that there's a high respiratory rate, high heart rate. We're going to do a cap refill. We're going to do look at the blood pressure. We're going to look at the patient's overall appearance. Are they pale? Are they cyanotic? Are they restless? Are they confused, disoriented? All those things. When we're doing a proper assessment on a patient, all these things should fall into place, and we should be able to identify a hypoxemic patient, not just off of a saturation. And then we take into consideration our blood gas and other labs and our chest x-ray, and it'll help to diagnose the patient better. The end.